So welcome everyone again to our National Fellows online lecture series. I'm Dr. Lee Mancini. We'll be serving in the role of moderator this evening with Dr. Matt Hall, who will be presenting. Dr. Matt Hall is the program director of UConn's Primary Care Sports Medicine Fellowship. He's also the UConn team physician responsible for caring with women's basketball, men's soccer, field hockey, women's ice hockey, baseball, women's rowing, and women's tennis. Dr. Hall completed his family medicine residency at Brown in 2012, and then his sports fellowship at UConn in 2013. He's an assistant professor in the Department of Orthopedics, as well as an assistant professor in the Department of Family Medicine at UConn. He also serves as a sports medicine consultant for Eastern Connecticut State University. I will say I've known Matt for almost 15 years now, and he's just an awesome, genuine, all-around great guy. And everyone's going to be in for a great CAQ review session tonight.
Right.
And
Thanks,
also,
Lee.
and next week we have abdominal pelvic trauma in sports with Dr. Ross Mathiasen will be the speaker, and Dr. Alex Tomesh will be moderating, and that's actually in 2 weeks, February 5th, not next week, but 2 weeks, February 5th, again at our normal 8:30 p.m. Eastern Standard Time. A couple of ground rules on the next slide that we have for the National Fellows objectives. Adjunct to serve as your home program's educational content. The purpose of these lectures is to provide fellows with direct access to educational experiences with AMSSM members and at times invited guest experts, and to assist everyone in CAQ exam preparation. Just some basic ground rules for those of you who are this may be the first time. Please mute your device's microphone and turn off your video. You can submit questions through the chat, although because tonight is a CAQ review, we'd say save your questions till the end and we can address them. And then I'll serve to go through your questions if we have time at the end. And then obviously there's an evaluation to complete at the end of this lecture, and it'd be great if everyone could fill that out as well. And then we definitely, those of us who serve on the National Fellows Online Lecture Committee, we want your input on either topics or speaker suggestions. You can go to amsssm.org under Education, and then under the Fellow Online Lecture Series, and there's a QR code you can scan, which will be on the next slide. And
that one didn't make it through.
That's all right. And so now I will turn things over to Dr. Matt Hall, and I will mute myself and mute my screen and take.
All right. Just kind of double checking, making sure everyone's good. Everyone can hear me okay. If not, please send something in the chat. So again, I'm Matt Hall. I appreciate Lee and Hamish Kerr from Albany Med inviting me and asking me to do this. And I also want to say a special thanks to my partner, Zach Moss, who is covering women's basketball, who are playing right now, so I could give this lecture. All right, so we're going to start with the first question. I would tell you that since I'm coming to you from the basketball capital of the world, that's not me. That's what they've branded us as. My questions have kind of a basketball theme to them, kind of what the team position that takes care of basketball kind of should know. This not all the questions, but try to make it a little consistent and some themes, some kind of repeat questions and themes to try to reinforce some topics. So without further ado, question number one. So you have a 20-year-old college basketball player that's hit in the face during a game. She immediately comes over to the bench holding her mouth. You suspect a dental injury. Which of the following is a true dental emergency requiring immediate transport to a dentist? Is it A, crown infraction, B, tooth fracture, C, tooth concussion, or D, tooth avulsion? All right, so we got a little bit of mix. We got 23% for A, 32% for B, and the majority for 45% for D. And D is the correct answer, tooth avulsion. So let's go through this a little bit. So a crown infraction, essentially think of this is an enamel-based injury, and definitely wanted to include dental injuries because basketball is a sport you're going to see it in. So a crown infraction is enamel only, and think of it as kind of like a crack or kind of a spider web type of appearance within the enamel. It might be kind of subtle, but you can kind of compare it to the other side. These generally do well. They should be seen by a dentist kind of in the subacute, maybe 24, 40 hours, but they are not require immediate transportation. B, which is a tooth fracture. So there are different types. I'm going to go into that. I have a couple of some teaching slides. There's different types of tooth fracture. Most of those need an evaluation by the dentist, but it is not a dentist. It is not an emergency. C, tooth concussion essentially is a contusion or injury. It often involves the root. It's self-limiting and not an emergency. And a tooth avulsion is your tooth out. So tooth completely out, tooth avulsion, which is requires immediate transportation. So just a little quick kind of tooth anatomy review, in case you don't go over it a lot like me, but the crown is the part of the tooth that you can see. You could grab onto if it were out on the floor. Then you have your outer enamel, and then you have your kind of deeper layer, which is your dentin. It has kind of a beigeish, kind of brownish kind of tinge to it. And then you get down to the pulp, which is where your nerve and your blood vessels are. And that's kind of important when you're talking about particularly fracture and the tooth infraction. So if we talk about the fractures, you have enamel-only fractures, which is essentially kind of like a rough edge of the tooth. They might feel like a little roughness of it. You might see a little kind of chip out of there. These are cosmetic. Sometimes they can be smoothed out or need a little kind of cosmetic touch-up. They're not typically very painful. Then you have your fractures involve the enamel and the dentin. And the ones that could be a little bit more urgent if it involves the pulp. And in those, you might see kind of a little bleeding or like a blood spot because you're all the way down to the vessels and the nerve. And then you have luxation injuries, which could be a subluxation, which is really could be subtle, where you have just a little, typically it's more posterior where the tooth's been pushed backwards. Those need to be dealt with in more of a kind of 24 to 48 hour kind of range and need to be kind of pushed back in place and typically splinted by the dentist, but it's not urgent. Lateral subluxation, which is a lateral luxation, can be a little confusing. And that's just a more obvious subluxation where the tooth is typically, again, more pushed backwards. I've had one of these several years ago, and actually our dentist happened to be there as a fan, came back and basically just reduced it, popped it right back into place, and pretty satisfying. And it's pretty amazing actually how stable the tooth was after that occurred. An extrusive injury is basically the tooth has been injured and kind of hanging on, but very loose. Those should bite down on the athlete should bite down something after forcefully trying to put it back in place, and that needs urgent transportation. And intrusive is a little bit more of a kind of worse injury because that's really the tooth is really driven up into the gum and can be needs urgent evaluation. And avulsion, the key is in reimplantation. So if the tooth is dirty, you want to grab it by the crown. If there's debris on it, you can rinse it with saline or cool tap water. Often they say milk, but who has that available readily? And you don't want to scrub it. You want to very just gently rinse it only if there's debris. And then 5-10 minutes, you want to get that reimplanted and then have the athlete kind of bite down on gauze, hold in place, and immediate transport. The implantation and reimplantation rate that's reported in the literature is actually higher than I would have thought. So just get to it quick. All right, so question number 2. Your college basketball player develops eye pain and vision change after a direct trauma to the eye. You observe the changes in the figure below. What is the best next step in the evaluation? Now, this picture I'll show you for a little bit, have you take a look at it, and then I'll go through what the potential answers are. All right, so hopefully you're looking at that and you have a diagnosis in mind. So is the best answer A, fluorescein stain the eye and examine for abrasion, allowing return to play only if normal? Is it B, observe and if the vision and pain improve, allow return to play? Is it C, refer to ophthalmology for close follow-up and return when cleared? Is it D, perform dilated eye exam if normal, observe for 4 days, and return to play? All right, so we have a majority for C with 82%, the majority for the correct answer, which is great. So hopefully you guys all looked at that and know that that's hyphema. And if you look at the answers, so A, fluorescein stain the eye and examine for abrasion, allowing return. A fluorescein stain could be appropriate. Obviously, it's something we do for looking for corneal abrasion. But if you did a visual inspection prior to, which you should always do, and you saw that hyphema, then that is not the best answer. Observing that the vision, if the vision proves, pain improves, allows return to play. Observation can be the treatment for it. I would not allow that to play immediately, nor would they want to. That needs a referral to ophthalmology, and it needs close follow-up. It needs a full eye examination. And really, with that type of trauma to cause a hyphema, you have to rule out other additional injuries in addition to that. So it needs a dilated exam, needs to check for the intraocular pressure. So that needs an urgent ophthalmology evaluation. And I would not perform a dilated eye exam myself on that. That should really be done by a specialist. So we're going into like kind of an eye, kind of facial trauma theme here. All right, so the next question number 3. You have a 14-year-old male that is hit in the left eye during a basketball game. He complains of blurry double vision. On exam, he has numbness of his left cheek and is unable to look up with his left eye. The athlete still wants to play. What should you do next? All right, so A, cover the left eye with a shield and send the athlete to the emergency room. B, cover the left eye with a pad and send the athlete to the emergency room. C, have the athlete wear sport goggles and return to play. Or is it D, cover the left eye with a pad and return the athlete to play? So we have 57% for A, we have 38% for B, and 5% for C. So it's good. So the correct answer is A. I mean, hopefully you were able to look at this and kind of quickly eliminate C and D. Even if it was medically okay to cover it and let them play, it'd be kind of hard to play basketball with one eye covered. So then you're down to A and B, and this really comes down to, well, is it a shield or a pad? So this case is concerning for a orbital floor fracture for a couple of reasons. One, you have numbness into the cheek, which basically is indicative of infraorbital nerve involvement, and the patient's not able to look up. So inability to look up, which means difficulty with upward gaze, which is a sign of a trapment of the inferior rectus muscle. The issue with this is that when you have trauma to the eye like this in the orbit, there are a high percentage of cases, like upwards of 30% potentially, where you would have globe injury in addition. And because of that, it's recommended not to have anything directly pressing on the eye. So the shield is a better answer. All right, so we're our facial theme still. So question number 4. So you have a 19-year-old male presents to your office after being elbowed in the face during a basketball game. He has swelling around the right orbit and tenderness along the orbit and zygomatic arch. He has outside X-ray films that reveal no fracture. He has no pain with range of motion testing of the eye, and it appears to have full range of motion. His pupil testing is normal, and he has no photophobia. His visual testing is 20/20 bilaterally. He does report diplopia with upward gaze. What are your appropriate next steps? Is it A, facial CT and referral to ophthalmology? Is it B, follow up in 4 weeks to see if the swelling has improved? Is it send to the ER for emergent surgery? Or is it D, reassurance that symptoms will resolve? All right, so great. So everyone did a nice job on this. We had a majority, 78% for A, which is the correct answer. So kind of a similar question to the last one. I included this because there are some differences which I think I'll talk about in a little bit. This patient a little different, has full normal range of motion, so no restriction with upward gaze, but does have double vision, diplopia with upward gaze. So that is something you would see with an orbital floor fracture. It potentially is something that could be treated not operatively, but it needs further evaluation. It needs a facial CT, so preferably a thin cut CT, 2 mm facial CT. X-ray, it doesn't have a ton of value in this, as patients already had X-ray. You can do X-rays when you're suspicious of these. I remember my mentor in fellowship talking about this, where if you have an orbital floor fracture, you can get blood in the sinus, so you can get a blood fluid level in the sinus on X-ray, but you don't see it all the time. So CT is your better test. But this patient has normal movement, so it's possible with swelling reduction in time. If the fracture isn't too big, they could treat it non-operatively. With the other one, it's much more of a surgical, more of an urgent situation, because there's probable entrapment of the inferior rectus that needs to be addressed. Follow-up in 4 weeks would not be appropriate. You need to actually follow, if you are going to follow this non-operatively, they follow these closely, because you can essentially get like a trapdoor effect, where the inferior wall of the orbit and the medial wall are very weak. And even if it looks okay, they can collapse, and then you can get further signs and worsening symptoms. Emergent surgery is not necessary for this patient, and reassurance would not be appropriate. All right, good job on that one. All right, so we talked about this a little bit. So just a little stuff on orbital floor fractures, because you will see these. Again, the history is important, the mechanism, how much force is there, where was it? So video is sometimes helpful, or if you weren't there. Visual change is super important. So, obviously visual loss, they can have blurry vision, but you have to kind of really tease that out. Like, do they have diplopia? Do they have photophobia? Are they seeing flashes and floaters, which is retinal detachment? Do they have a visual field defect? Again, that's retinal detachment. Eye pain. And then are they reporting any numbness, which can be from the infraorbital nerve, that can be into the cheek or into the lateral nose. And then on exam, you're looking for asymmetry. You're looking for the pupils being equal. There can be actual asymmetry of the pupil itself, which sometimes you see with foreign body or globe rupture. I have a tough time with this word. So enophthalmos, which essentially is the eye is kind of sunken back. We talked about that kind of trapdoor kind of phenomenon. Or if you have larger facial fractures that are more complex, you can get some asymmetry, and that can be a bit subtle. We'll talk about that in a bit. Limited upward gaze is important. Inferior rectus entrapment is what we're looking for there. And they have diplopia with vertical gaze. They have subconjunctival hemorrhage, and sensation is important. All right, so kind of similar thing, but again, I'm trying to reinforce these things. So hopefully when it comes time for the exam or you see this stuff that it's reinforced for you. So question 5, you are covering a basketball game and are called to assess a player who took an elbow to the left side of the face. After ruling out a cervical spine injury, you assist him to the locker room where you begin to evaluate him for a possible concussion. During your ophthalmologic examination, you become concerned that he may have sustained a facial fracture. Which of the following symptoms and physical exam findings is most indicative of a fracture of the lateral orbital wall? Is it A, limited upward gaze? Is it B, paresthesia in the V2 distribution of the trigeminal nerve? Is it C, 360-degree subconjunctival hemorrhage? Is it D, pain with opening the mouth, otherwise known as trismus? Or is it E, blind spot on the edge of the visual field? All right, great. So we got a majority for B and 59%. We have 18% for A, and then kind of, couple for C, D, and E. So, okay, great. So the correct answer is pain with opening the mouth, which is trismus. So obviously, this is a challenging question. And when I read it, I thought it was challenging, which is why I wanted to include it. And I put it right after the other one because they throw in at the end, this is a lateral orbital wall fracture. So lateral orbital wall is not as common. It's much stronger. That part of the orbit and the superior part of the orbit are much stronger. So your inferior, your floor and your medial kind of aspect are going to be much more common. So your limited upper gaze is something you're going to see with a floor fracture, which is what we were talking about before, as well as you could see paresthesias in the V2 distribution of the trigeminal nerve. The lateral part kind of throws it off. A 360-degree subconjunctival hemorrhage is seen with a globe rupture. And a blind spot on the edge of the visual field would be retinal detachment. So because of this location, when you get to lateral orbital fractures, there's a lot more trauma typically and velocity. So higher velocity injury, and they also are associated with kind of more complex fractures. And you see in the coming slides with the anatomy of where it kind of tracks down, that it kind of tracks from the zygoma down to where the zygoma or the zygomatic bone reaches the sphenoid bone. That comes down to your zygomatic arch. And when you open and close your mouth, that's going to cause pain. And it really it boils down to these tend to be more complex injuries. I have a slide about that to show you the anatomy in a bit. So just stay tuned. All right, so number 6, which of the following is correct about acute zygomatic complex fractures? Now this one, I watched the other lectures and Nathan Cardus, who did his many months ago, had this one in, and I elected to keep it in because many of you probably didn't watch that one, but if you did and you got it wrong, hopefully you got it right here. So again, which of the following is correct about acute zygomatic complex fractures? Is it A, raccoon eyes are pathognomonic? Is it B, pupil levels are unequal? Is it C, these are the third most common facial bone fractures related to sports injuries? D, involves the mandible and associated bony structures. All right, so, okay, cool. So we're kind of across the board here a little bit too. The most common answer was D, and then followed by answer C, and then A, and then B. So the majority was D, 43%. So actually the correct answer is B, pupil levels are unequal. So we'll talk about this a little bit. So zygomatic complex fractures, we talked about this, and maybe our prior question kind of influenced you where opening and closing the mouth with trismus can cause pain, but it doesn't involve the mandible itself. And you'll see that on my anatomy picture coming up. Hopefully raccoon eyes is pathognomonic for basal skull fracture. And then C, when I did this question, it was kind of between, B and C. So C, these are the third most common facial bone fractures. Number one is nasal fracture. Um, and believe it or not, this is number two. And then three, they said was mandible in the question stem. The pupils level are unequal, I think is a little tricky because when I read it, you think, well, pupil level is unequal. You think about like the actual, the whether the pupil is constricted or dilated or is there asymmetry. But with these complex fractures, you can actually, we talk about the asymmetry where the pupil levels can actually be unequal where they're not level, and you can get that the eye can be sunken down, and that is one of the things you want to look at on your evaluation. I'm going to show you a couple of pictures here. So shows you a little bit of anatomy, this kind of side view where you have the zygoma or the zygomatic region here that comes over to the zygomatic arch on the left side, and the zygomatic region, it basically has a suture with the greater wing of the sphenoid, and so fractures can kind of really traverse down there, and then obviously you can get fractures all the way down into the zygomatic arch. Now, this part of your cheek is very strong. So if you have direct impact, you're going to have significant velocity for that. And with that higher velocity, you're likely to get complex injuries. So on the right, you have this very complex fracture where you could see we have this involvement of the lateral wall, which you talked about in a prior question. You even have this fracture down in the inferior portion, then it extends all the way here. You have this complex fracture of the arch. But the mandible itself isn't actually involved. And you can see how this person would have pain with trying to open and close their mouth. Now here's a picture from a journal article that I pulled, and I picked this one out specifically because it's not super obvious. So if you look at the picture on the left, there's this kind of asymmetry kind of in his right eye where there's a kind of drooping of the lower lid. But if you draw a straight line like from his left eye to his right eye, his left pupil is certainly sitting slightly inferior. So that's what they're referring to, these complex injuries that are essentially unstable fractures. Then you say like, well, okay, Matt, like why are you showing me this? Because what's the probability, of seeing this? Well, unfortunately, this stuff does happen, and this is a real case that we had several years ago, and it didn't seem that significant. It was a ball that hit one of our athletes kind of in the left cheek area. It came off and was evaluated, had swelling, and the eye eval was I was not the doc there, but it was actually my patient. I just wasn't there at the time, and so the eye eval was good and reassuring, and the athlete went back, and swelling came down the following day, had follow-up, and some depression was noted. And so you have a couple of x-rays where we're talking about kind of with the orbital fractures that the value of the x-ray isn't as great, but with some of these facial ones and this pain, and there was a little depression around the arch, you can see some stuff with x-rays. So on the left picture, or on my left, the patient's left, there's a little asymmetry of the zygomatic region on the left side. On the right, it's much more evident on the picture on the right, which if you look on the right, you see this complex fracture with this depressed fracture here where the ball directly hit this. And this needed a reduction actually done by one of our ENT docs. And that's the other thing with these facial things, where wherever you end up, there's going to be some variance in who deals with these, and depending on what the fracture is, some ENTs will do it, some might be OMFS, it could be some, ophthalmology. So there's going to be some variance in your institutions. Believe it or not, they reduced this by a small incision around the hairline here, and they place a tool here down through here, and they essentially reduce it that way, which is pretty wild. All right, number 7. A collegiate basketball player is struck in the eye at practice. Her visual acuity is normal, but she is describing floaters in her eye. Which of the following is true? Is it A, since her visual acuity is normal, retinal detachment is ruled out? Is it B, this is a classic description of an eye contusion and should resolve within 24 to 48 hours without complications? Is it C, visual fields will often be normal on exam? Or is it D, a Marcus gun pupil may be seen? All right, we got a majority for C, 67%. And the next would be D, and D is the correct answer. All right, so let's talk about. So hopefully, you read this, and reading this, you're thinking uh, a retinal detachment. Um, And then the next question is what to do. So since her visual acuity is normal, retinal detachment is ruled out. And that's actually not the case. So you can actually have, particularly with some peripheral injuries, you can have normal visual acuity. That doesn't rule out retinal detachment. If you have direct trauma to the eye and there are floaters, this should not be classified as any type of contusion. That needs to be further evaluated. So visual fields will often be normal on exam. So visual fields can be normal, but it's not often. So always with these board things, always be kind of test taking skill is always be mindful of kind of the more extreme answers where they say always, or in this case, visual fields will often be normal. It's kind of vague. And then a Marcus gun pupil may be seen. And in full disclosure, I include this question because I had not heard of that phrase when I was preparing for this. So if I learned something, I feel like you guys would learn something. So a Marcus gun pupil, it's pretty interesting. So, I mean, with that history itself, my suspicion for a retinal detachment is quite high. So I think my plan would be pretty clear at this point. But what this is it's a relative afferent pupillary defect. And essentially it's looking for there's different things, but in our world, it is potentially optic nerve injury or retinal detachment. And what it is kind of an abnormal response. And as we know, it's this kind of swing test with this swing light test, they call it. But when you shine a light in the eye, the pupil restricts, and you get a compensatory constriction in the opposite eye. So the top one is no light. The middle picture is normal response. You get constriction of both. And if you swing the light to the then affected eye where you're worried about, in this case, it's a retinal detachment, instead of that eye then constricting and you get basically a reciprocal response and you get dilation, which is an abnormal response. The optic nerve is responsible for the afferent, pupillary reflex, and in that case, you're more concerned about the injury. In this case, direct trauma, floaters, but this is kind of a nice board question in case that ever comes up. Marcus gun pupil. All right. Number 8. Which nerve is injured in a shoulder that presents with lateral scapular winging that worsens with the hands on hips or lowering from forward arm flexion? Is it A, spinal accessory nerve? Is it B, dorsal scapular nerve? Is it C, suprascapular nerve? Or is it D, long thoracic nerve? Dreaded scapular winging. All right, so we have a majority for D, 55%, but we did have 30% for the correct answer, which is B, dorsal scapular nerve. I think again, these are I think a fair amount of them are pretty challenging questions, and long thoracic nerve has long been kind of drilled into our brain as a potential for scapular winging. So it kind of makes sense to me that that would be the majority. So let's talk a little bit about this. Hopefully, you guys looked at this and you could quickly eliminate C with suprascapular nerve, which is innervating your cuff with your supra and infraspinatus. And that should not directly lead to scapular winging, lateral scapular winging, so you could rule that out. And then it's just a matter of kind of knowing which of these causes lateral scapular winging. So let's talk a little bit about this. So just for a refresher, so your spinal accessory nerve, that is primarily innervating your trap. And your dorsal scapular nerve is primarily innervating rhomboids, but also serratus. Also levator scapulae. We talked about suprascapular nerve. And then long thoracic is our serratus anterior. So a couple pictures. So down on the kind of bottom left, you have classic, medial scapular winging from the long thoracic nerve. So serratus helps stabilize that, and you're with the long thoracic nerve palsy, you get medial scapular winging. With the spinal accessory nerve, you're going to get lateral scapular winging. So that's this one on the bottom right, and that's trap. And trap is responsible for helping keep pulling this kind of medially, but also it elevates. So you're going to have this kind of drooping or depressed scapula as well. Now the dorsal scapular nerve with the rhomboids, it also causes this kind of medial kind of border here. But what happens is when they go up into this flex position on the arms and the hip, they're going to get more lateral winging than you would here. So if you look on this top left one, when the patient's arm are at the side, this inferior medial border of the scapula is shifted laterally and kind of rotated down, as opposed to the medial border of the scapula here on the long thoracic nerve. So somewhat of a difficult question there, but definitely review your nerve innervations prior to boards. All right, next. So you have a 16-year-old high school football player impacts his right forearm against an opponent's helmet while tackling. He complains of pain over the point of impact of the dorsolateral aspect of the proximal right forearm. He subsequently notes weakness in the right wrist with extension and finger extension, but no pain or tingling in his hand. His exam is remarkable for tenderness over the proximal edge of the supinator muscle, and he has diminished strength 4 to 5 with wrist extension and thumb and finger extension at the MCP joints. Diminished strength with forearm supination is also noted. Sensation is intact, a light touch over the radial and medial distributions. X-rays of the right radius and ulna show no fractures or dislocation. His most likely diagnosis is it A, extensor tendon rupture? Is it B, Wartenberg syndrome? Is it C, anterior interosseous nerve syndrome? Is it D, posterior interosseous nerve syndrome? All right, great job, everybody. So we got 64% for the correct answer, which is D, which is great. That's the correct answer. So strong work on that. So yeah, we'll talk a little bit about this. So hopefully quickly, extensor tendon rupture, one, you don't really see that. But hopefully we were reading the stem, you're thinking neurologic. And the big key in this, in some of these neurologic questions is picking out if there's weakness or not. And if you can pick out if there's weakness, which in this case there is, that really helps you. So if you know motor function of certain nerves, that can help you narrow things down. So Wartenberg syndrome is actually a sensory issue. So it's a superficial, it's radial, superficial radial, and you'll get kind of numbness down into the hand, dorsum of the hand, into the thumb. And it's typically said that it happens like you have something compressing on the forearm that would then kind of put some compression on the nerve itself. And it's not, shouldn't involve motor, so it's sensory. So that brings you down to anterior interosseous nerve and posterior. And then you might have read this question and been like, yeah, this is radial nerve. Hope you did. They didn't give you that. They gave you the branch. You guys seem to be pretty on that. So just to kind of refresh your kind of memory a little bit, just quick, where you have your radial nerve coming kind of laterally over that kind of epicondyle, which can be kind of these can be sources of kind of lateral elbow pain or symptoms that don't get better that you are initially treating as kind of lateral epicondylosis. So the radial nerve splits, and you have the superficial radial nerve, and then the posterior interosseous nerve, which is motor only, comes down, and right here along the edge of the supinator is this area called the arcade of Frosch, which is an area of potential entrapment and palsy. And then the anterior interosseous nerve is also primarily motor, but that's median nerve. And just not related to this question, but a way of testing that, they talked about wrist extension weakness in the stem, you have them do an OK sign, the anterior interosseous is providing motor function to the flexor pollicis longus and the flexor digitorum profundus on the radial aspect. So if they can't do an OK sign and they have weakness there, could be an issue with the anterior interosseous nerve, and that's median nerve coming down this kind of medial side and then splitting down here. All right, number 10. During a basketball game, a 20-year-old collegiate basketball player jammed her fourth finger on her dominant hand. When evaluated on the sideline, she is unable to extend her finger at the DIP, distal interphalangeal joint. She is taken to the locker room and x-rays revealed no fracture. What is the next appropriate step in treatment? Is it A, referral to orthopedic surgeon? Is it B, apply an ulnar gutter splint? Is it C, buddy tape to the third finger? Or is it D, apply a stack splint? All right, great. So of my questions, this one's a little on the easier side. So it is reflected here 63% with D, which is the correct answer, which is apply stack splint. So this is what I call soft tissue mallet. So this is, often we talk about it with a bony fragment, but this is just the tendon avulsion. And the treatment for that is stack splint, which is pictured here. Kind of great little thing to have in your office, and it should be is a little bit better than the dorsal kind of aluminum splint, and it does allow for a little bit more of that hyperextension, a little easier. You can't get maceration of the skin under here, so you got to be careful of that. Buddy tape would be appropriate for jammed finger, volar plate avulsion, ulnar gutter, which could be used, metacarpal fracture, fifth metacarpal as initial treatment or potentially definitive treatment, depending on who you talk to. And these can be treated non-operatively. The referral to orthopedic surgeon, to your hand colleague, would be typically if you have a large bony fragment, 50% more, but really more like that the joint is not congruent and it's unstable. So if you have a large enough fragment that the joint is not stable and you get volar displacement, and that's not going to do well. So that's the surgical indication. Fracture, no fractures were noted on this x-ray. Super common, obviously, in sports, but definitely in basketball. So I got to include that one. All right, number 11. Which of the following is the preferred technique for attempting reduction of the DIP or PIP dorsal dislocation without fracture? Is it A, provide longitudinal traction with hyperflexion and gently push the base of the dislocated phalanx into place? Is it B, provide longitudinal traction with hyperextension and gently push the base of the dislocated phalanx into place? Is it C, provide longitudinal traction while applying ulnar and radial stress to the base of the dislocated phalanx? Or is it D, provide mild longitudinal traction with PIP and MCP joints flexed? All right, good. So we have 42% for A, and the majority for B, 53%, but not by much. And B is the correct answer. So this dorsal dislocation, again, very common. If people all got this far, I was going to talk a little bit about the fact that, when do you actually try to relocate these, and for dorsal dislocations that come up, often the AT is kind of relocating those before they even, get to you, but trying to get them back into place as quick as possible. And those that are stubborn, not going back, then there may be a fracture. Obviously, if you have fluoro there or the ability to x-ray it quickly before you do that, you certainly can. But even if you have a displaced fracture, in some ways, quickly trying to see if you get it reduced, essentially you're reducing the fracture, unless the patient's skeletally immature. This is dorsal dislocation, which is super common. If it were a volar dislocation, then the answer would be A, which is longitudinal traction with some hyperflexion. This is traction with hyperextension, and that's the correct answer. So, good. All right. We're continuing our finger theme. So 12, a basketball player presents to you following practice with an injury to the right third finger. On exam, you note a positive Elson's test. You are concerned that this injury may go on to develop a boutonniere deformity. Which of the following correctly describes the mechanism causing this deformity? Is it A, rupture of the extensor central slip of the PIP with subsequent volar displacement and contraction of the conjoint lateral bands? Is it B, avulsion of the flexor digitorum profundus tendon at the DIP? Is it C, disruption of the extensor mechanism of the DIP? Is it D, extensor tendon subluxation at the MCP joint? Or is it E, rupture of the extensor hood of the MCP joint? All right, great job on this. So majority is A, 71%, which is the correct answer. I wanted to include this one because the answers themselves don't make it super challenging because if you have a little bit of knowledge, you can kind of eliminate some. So, avulsion of the flexor digitorum profundus, that's Jersey finger. We just talked about disruption of the extensor mechanism at the DIP. It's a mallet, either bony mallet or soft tissue mallet. Extensor tendon subluxation at the MCP is an injury to sagittal band, so you get instability of the joint at the MCP. Rupture of the extensor hood is not super common. It's more of an extensive injury involving the kind of connective tissue and kind of the coating over the extensor tendon at the MCP, and it can be seen in like combative sports like boxing. So this is central slip injury, and I wanted to include it because for the amount of times you see a jammed finger, PIP joint, that you're always going to be mindful of central slip, and an Elson's test is important. So make sure you're kind of doing that as part of your evaluation. And for those that don't, the Elson's test is essentially you can have them flex at the PIP joint, and then they resist that. They try to extend the PIP joint against your resistance. And when they're doing that, you're looking to see what's going on with the DIP joint. If the DIP joint is floppy, then your central slip is intact. So you want it to have it be floppy, like you could do it yourself. And that means that when they're trying to extend, they're using their central slip. And when I was a fellow, I had a hard time wrapping my brain around this. And once I kind of got rid of the idea of the central slip is if you think of it, it's the extensor of the PIP joint. And if you just think about it that way, it simplifies it. And if that's intact, then you're going to extend using that. If it's not intact, you will be able to try to extend it. But what you're going to do is you're going to use your extensor down at your DIP joint. So in order to do it, you have to really fire the extensor tendon connecting way down at the DIP joint. So when you do that, your distal phalanx is going to be rigid. And that's an indication that your central slip may be disrupted. So really important to do as part of evaluation. You guys are right on that. So good job. Here's a picture of it where the left is showing this is where it was cut, but and it's like a surgical picture. But I really like the kind of picture where you have the central slip that's kind of off here. You see where it's attaching here, and then you see how your terminal extensor comes around and connects to your DIP joint. All right, we're getting towards the end here. A couple more. So 13 is a 35-year-old runner training for a marathon. It presents to you with gradually increasing pain in his midfoot. There is no history of acute injury. You diagnose a tarsal navicular stress fracture. Which of the following is correct regarding the assessment and management of this injury? Is it A, fracture boot with crutches, weight bearing is tolerated for 4 to 6 weeks? Is it B, postoperative shoe with rigid orthotic and crutches for 6 to 8 weeks? Or is it C, short leg, non-weight bearing cast for 6 to 8 weeks? Or is it D, MRI and CT imaging have little value if plain radiography images are normal? All right, we had 65% for C, 30% for A. So C is the correct answer. So good job there. So short leg, non-weight bearing cast, 6 to 8 weeks. Now, I wanted to include this for a couple of reasons. I almost changed this to a basketball player. So you have a 35-year-old runner here, which is important in this as far as the treatment. So, and you diagnose, and it says tarsal navicular stress fracture, which is interesting. So I wanted to bring up this point of just make sure you're being clear about what language you use. And we use stress fracture a lot interchangeably with stress reaction, but it really can be important in how your treatment is. And so with them saying tarsal navicular stress fracture with this, there was part of me that was, initially thinking I was looking for a surgical treatment on here. It is a recreational runner, and the outcomes for non-operative treatment um, can be good with non-weight bearing in a cast for 6 to 8 weeks. However, this is a higher risk stress injury. And I would tell you at the kind of collegiate, higher collegiate, professional level, if you have a stress reaction, it can be treated non-operatively. However, if you have a fracture line, either on X-ray, on MRI, typically in my world, we are looking at getting that fixed with a screw. And really, it's a matter of trying to get them kind of back sooner. And so the treatment can change a little bit depending on what your patient population is. So our typical thing would be if we have an X-ray, we have a high clinical suspicion of a navicular stress injury, the X-ray does not show it, but when you do see it, it's kind of in the central portion, kind of at the tail navicular joint is the most common. If there's no stress fracture on the X-ray, get an MRI. If we see bony edema with no clear fracture line, oftentimes we'll get a CT scan to make sure there's no break in the cortex. It's a higher risk stress injury. And that kind of helps us make our decision from there. Good job on that. All right, so number 14, you are covering a women's collegiate basketball game when one of your players suffers a non-contact knee injury. An MRI after the game confirms a full rupture of her anterior cruciate ligament. She comes to you in clinic and has questions about the surgery. Which of the following is correct regarding the type of ACL reconstruction, the outcomes, and complications? A, bone tendon bone has a higher rate of post-surgical anterior knee pain and higher re-rupture rate compared to hamstring autograft. Is it B, BTB has a lower rate of post-surgical anterior knee pain and a lower re-rupture rate compared to hamstring autograft? Is it C, BTB has a higher rate of post-surgical anterior knee pain and a lower re-rupture rate compared to the hamstring graft? Is it D, BTB has a lower rate of post-surgical anterior knee pain and a higher re-rupture rate compared to the hamstring graft? All right, we have a majority for C, 58%, which is the correct answer. So good job on that. I include this because I wanted to make a note of it with these kind of basketball injuries, and your patients will ask you about these even as primary care or non-operative providers. So it's important to know, and also like making sure that again, whether it's a high-level athlete or not, seeing young patients, our preference here is we've seen a little bit more quad tendon, but BTB is kind of the preference, and they do get anterior knee pain, but there are ways of trying to mitigate that. All right, so this is a good one. So 15, you have been treating a 36-year-old male runner for chronic recalcitrant right plantar fasciitis for several months. He has pain consistently located at the plantar aspect of the calcaneus around the medial calcaneal tuberosity, without other bony tenderness, and worsens from the morning throughout the day while walking for his job. He denies numbness or paresthesia and has normal strength in his foot, although he notes occasional discomfort when flexing and abducting his toes. He has only limited response to treatments, including rest, night splinting, direct and indirect fascial massage, flexibility, oral medications, and a trial of booting and orthotics. Ultrasound imaging 2 months prior demonstrates calcaneal osteophyte at the insertion of the plantar fascia and a mild thickening of the fascia itself, without evidence of degeneration. Due to his pain limitations and chronicity of the problem, you decide to obtain an MRI. What would you expect to find on the MRI? Is it A, rupture of the plantar fascia? Is it B, edema of the abductor digiti minimi? Is it C, calcaneal stress fracture? Or is it D, tenosynovitis of the flexor digitorum longus? Long stem, those are kind of tough when you're on a board exam. It's a lot to kind of go through. And sometimes you get through that whole stem and the actual question itself is really not that related. But I think this is a good question. All right, great. So we have 0% for A, so good job on that. We have 17% for B, and we have 56% for C, and 28% for D. All right, great. So the correct answer is actually edema within the abductor digiti minimi. So I read this question, and my brain quickly went to the tenosynovitis of the flexor digitorum longus. And I thought as what they were kind of getting at is you can get kind of an intersection syndrome in the foot where the flexor digitorum longus and the flexor hallucis longus crossover. It's a little bit more like arch pain, and that's called the knot of Henry. It's a pretty cool area in the foot, but they do say that this is heel pain. A calcaneal stress fracture, which was was a common area, really typically gives pain kind of over the kind of medial lateral portions of the calcaneus, and it's a little bit more diffuse rather than this kind of focal plantar pain. Certainly, this is presenting like plantar fascia pain. There's no indication that there was a rupture. And the answer is edema of the abductor digiti minimi. So what they're trying to get at is a Baxter's neuropathy, which is kind of down the list of patients with heel pain that's just you think is plantar fascia and just isn't responding. You do an ultrasound, the plantar fascia doesn't look that bad, and you're like, this should get better with a little bit of treatment. It's just not responding. So I always thought of that as something that was kind of a diagnosis of exclusion. A lot of these neuropathies are. EMG isn't really great for it. But it's pretty interesting to kind of learn that you can get some MRI findings. So just kind of little, we're going to look at the picture on the right here. So if you look in the nerves in the medial ankle, you have your posterior tibial nerve, and as that comes, you branch, you have the medial plantar nerve. Then you have your lateral plantar nerve. Now the Baxter's nerve is otherwise known as the first branch of the lateral plantar nerve. And if you follow this pictorial, it's kind of running along, and this muscle right here is your abductor hallucis, kind of thick muscle that helps with your large toe. And then you have your quadratus plantae. And this is an area of potential entrapment. And then it courses down here. And the other potential area of entrapment down here, there's a little bit of a risk if you have a calcaneal enthesophyte, which is, or spur, which is referenced there. And it courses down here, and it provides motor function to the abductor digiti minimi. And so on an MRI, if you have a significant neuropathy, you could see some edema, you could see atrophy of this. And so if you are lucky enough to pick that up, it will help. Otherwise, this is kind of a diagnosis of exclusion. It's just pain not responding to plantar fascia treatment. And sometimes with these neuropathies where we kind of use ultrasound and kind of little blocks, diagnostic blocks, to see if we can help the patient's symptoms to help make a diagnosis. This is another picture of it where you see the tibial nerve, posterior tibial nerve here. You have the branch, which is the lateral plantar nerve. This first branch is the Baxter's nerve, and it comes over and provides motor for abductor digiti minimi. All right, last one. So you have 16. This is a great question. I'm going to end with this one. So as a team physician, you're covering a Final Four tournament game. You are asked to evaluate one of your players 30 minutes before game time. Your athlete has been feeling ill for the past day with acute onset of body aches, chills, cough, and fatigue. You examine him and find his temperature to be 103.1 degrees Fahrenheit. What is the most appropriate course of action for your athlete? Is it A, give acetaminophen, recommend he drink 16 ounces of water and allow him to play if his temperature is decreased by the time of tip-off? B, given acetaminophen, isolate him from the rest of the team and do not allow him to play, even if his temperature is decreased at the time of tip-off. C, give acetaminophen, isolate him from the rest of the team, and allow him to play if If his temperature is less than 100 degrees at the half. Is it D, give acetaminophen, recommend he drink 16 ounces of water, and allow him to play if his temperature is decreased by the second half of the game? Yeah, 95% we got answer for B, which is the correct answer. Although I put this in because I would tell you it's not that easy. This one they made because it's 30 minutes before the game, and even though Michael Jordan supposedly, I think, was in the finals and had the flu and had this great game, 30 minutes before the game, it's pretty clear. Even if you got them well enough that they could get out there, the chance of performing well is basically slim to none. I've had similar situations, not like this, but be prepared for these type of things because if you're, a team physician, these things will come up, and especially you have these big games or championships, and it does put us in positions where the question is this actually medically safe for the athlete or not? So I thought this was a nice one to end with. I want to thank you guys for kind of your attention, and Lee, if you're still with me, then I guess I'll let you take it from here.
Thank you so much, Matt. What a great job. Great questions, great teaching slides. As always, when you've done these for our regional sessions in New England as well. At this point, if there are any questions in the chat, feel free. Otherwise, thank you, everyone. And please don't forget to fill out some feedback on tonight's session, as well as using the QR codes to look for additional topics, additional speakers.